So it is my absolute pleasure to introduce Dr. Celina de Borja, who's our conference chair and has put in all this hard work to create this experience for us all. And she's going to be talking today on the topic of optimizing bone health in young athletes. Dr. de Borja, she's a pediatrician with sports medicine fellowship training, and she cares for children and young adults of a wide variety of MSK conditions, a lot of which we talked about today. She completed her pediatric residency at Hackensack Meridian Health at Jersey Shore, and then completed fellowship in primary care sports medicine at Boston Children's Hospital. She, at UCSF here, she's really active with the Play Safe and Run Safe coverage programs, which serves a variety of sporting events in the Bay Area. And she has particular interests in dance and performance medicine, and also serves as a team physician for the SF Ballet. So with that, we want to welcome you, Dr. de Borja.
Thank you, Rhonda. All right, good afternoon, everyone. Thanks, Rhonda, for that introduction. And so as part of the course planning committee, I got to assign myself a talk, and that will be optimizing bone health in young athletes. And that's because it's a topic that really I find very interesting. And so I find it very exciting. And it turns a 15-minute fracture visit into 45 minutes, which is great for the patient, but gets me in trouble because I'm behind in the rest of the clinic. So while I don't have any financial disclosures related to this talk, I just wanted to reiterate my background is in primary care pediatrics and sports medicine. So both avenues have allowed me to explore this interest in bone health through working with various specialists in medicine, as well as nutrition and mental health. I am, however, not an endocrine specialist, which limits the scope of this topic. So when things get a little bit complicated, I myself do phone a friend. And so our two main objectives for today include recognizing conditions that may interfere with adequate bone health, and then also to review strategies to optimize bone health in children and adolescents. So before we begin, what is bone health? According to the US Surgeon General, bone health is a public health issue with an emphasis on prevention and early intervention to promote strong bones and prevent fractures and their consequences. Now, why is that important? Aren't bones used for movement? Well, not really. Not just movement, not just mobility. Bones are important because they protect our vital organs. The skull protects the brain, our rib cage protects our heart and lungs and, other important organs as well. And they're also involved in essential cell production, say, red blood cells, immune cells. The bones help with, regulating electrolytes, specifically calcium. Now, when do we need to start talking about bone health? And the answer is now, or as soon as you possibly can. As you can see on the photo on the right upper hand corner, children have this unique risk for fractures just by, one, being skeletally immature, and two, just by their activity levels. And everyone in this room has probably seen a successful and unsuccessful outcome from that photo, which keeps us busy in practice. But most importantly, 90% of peak bone mass is actually attained during childhood and adolescence. And so, as you can see in the photo in the right lower corner, the process of collecting calcium into your bone bank is in this upward slope in your first 3 decades. And then this process becomes slower in your 30s. Then after 40, the skeleton begins to slowly lose more bone than it forms and can lead to osteoporosis. And it's funny, every time I see this photo, whether when I'm reviewing a talk or, listening to a talk, it always, makes me think maybe this is where they got the phrase, it all goes downhill after 30. Now, where do we even start? Who remembers this diagram from Physiology 101? This diagram has always intimidated me since, my early days of medical training. It's calcium homeostasis. There's a lot of enzymes. There's arrows that point up. There's arrows that point down. But I like to keep it simple, as Carly said. There's 3 organ systems and there's 3 hormones. Okay, ready? So 3 organ systems include the bones, the gut, and the kidneys, right? And these 3 organ systems are controlled by the 3 hormones that regulate calcium. And the 3 hormones include parathyroid hormone, or PTH. And PTH's goal is to keep calcium in the serum. So most of our calcium is stored in the bones, and the rest is in the bloodstream. And PTH's goal is keep it in the serum. So when PTH acts up, it takes calcium from the bones. And then secondly, it also increases reabsorption of calcium from the kidneys as well as absorption from the gut. Now, absorption from the gut happens through vitamin D, which is our second hormone. Vitamin D is essential for absorbing calcium from our diet. Without vitamin D, we're just flushing out all the calcium that we're getting from all that dairy or non-dairy products. And then lastly, calcitonin. Calcitonin works opposite of PTH, so calcitonin likes to keep calcium in the bones through reverse mechanisms. Simple, right? Now, who needs to have this conversation about bone health with our children and athletes? And the answer is all of us, everyone in this room. You know, you could be a clinician, or you can be someone who works in the sports industry. So you can work in primary care, you can work in a subspecialty like orthopedics or rehab. You could be a physical occupational therapist, athletic trainer, mental health, or nutrition. Everyone needs to stay involved in the conversation regarding bone health because certain risk factors may be more obvious in certain clinical settings. Which brings me to my first objective, which is recognizing conditions that may interfere with adequate bone health. We'll start with intrinsic risk factors, and as Dr. Watkins mentioned earlier, these are factors that we can't really do much about, but they're very important so that we can identify, who may be at risk. So with age, I mentioned earlier, adolescence is a period of rapid growth, so there may be impairments in bone mineral density, as well as in elderly individuals. Gender also plays a role, as we heard from Dr. Watkins' talk a while ago. Women are more at risk for bone stress injuries or other overuse injuries, such as compared to men. And then genetics. While we see these bone health impairments in a wide variety of race or ethnicity, we somehow see it most commonly amongst white and Asian women, especially when there's a family history of osteoporosis. Now, for those who work in primary care, who know our patients best, think about bone health in those with certain medical factors. So first, there's GI or fat malabsorption. So in kids with inflammatory bowel disease, celiac, or cystic fibrosis, always want to think about their bone health. A lot of times, GI disease, such as IBD or celiac, is not early diagnosed in the kids because they're, very nonspecific symptoms. So usually I ask them if they have, sensitive stomachs, if there's food groups that they tend to avoid because it makes their stomach upset, if they can take dairy well or not, things like that may lead you to maybe investigate further towards a GI problem. Next is, any kid with a chronic disease. So whether it's liver disease, kidney disease, because we know that our hormones, especially, calcium and vitamin D, are all metabolized through the liver and the kidney. Childhood cancers or chronic disease. As we learned from Dr. Lawson yesterday, our rheumatologic patients or those with inflammation could also have low vitamin D, and so she screens them for vitamin D. And then obviously endocrine conditions. Next would be medication exposure. So steroids are a big one that we consider for impaired bone health. A lot of times we think about steroids in those with rheumatologic or inflammatory conditions, right? But don't forget the respiratory kids. So when I was in primary care pediatric training, I was training in the East Coast, and we had very harsh fall and winter seasons. And when those seasons hit, it was very hard on our respiratory kids. They would get these respiratory flare-ups. And, at some point I felt like I was on like a reality show. It was like, you get steroids, you get steroids, you get steroids. And no one really pays attention to these things because, when you look at them, you spend 3 years with a family, for example, in medical training, you realize they've had a steroid burst maybe 2-3 times in that winter, for the past 3 years, and that could have, affected their overall bone health. I was also trained in pediatric primary care to give inhaled steroids for asthma control, right? We want to avoid these steroid bursts for asthma exacerbation by inhaled steroids. However, I did meet a patient in my clinic for multiple fractures who's had some, endocrine abnormality like growth hormone disorder. And she was seeing a specialist, and when they did her overall eval, she was saying that it was secondary to her inhaled steroids. So even though, and that was very surprising to me as well, because I was taught to just give inhaled steroids to everyone for control. But, it really was such an eye-opener to be very prudent about these medications. And, just because they say, inhaled is more benign or less toxic than oral steroids, it may not be for everyone. And so just wanted to let you know about that. And then other medications that are also implicated in impaired bone health include anticonvulsants. So, we do have a lot of children maybe with neuromuscular conditions or have seizures, coexisting seizures on these medications. Antifungals, antiretrovirals, and antidepressants. It has something to do with the cytochrome P450 metabolism. Again, we'll keep it simple. So we'll just leave it at that. And then last but not least, mental health or behavioral conditions also has something to do with bone health. So this is in the setting of eating disorders or disordered eating or undernutrition. So it's important to think about bone health in that setting as well. For us who work in orthopedics or maybe rehab medicine, we also consider, bone health workup if we're seeing them too often for bone injuries. So if they're becoming a frequent flyer for recurrent fractures. So usually 2 or more traumatic fractures in childhood. It makes me think about, doing a bone health workup. That's also actually the time that the parents start asking questions like, everyone's taking a spill in the playground. Why am I here all the time, right? Why am I getting these injuries? Is there something else, right? Stress fractures. There's, low risk and high risk stress fractures. But this is a condition where we have kind of low threshold to think about bone health. Vertebral compression fractures, especially when they're low energy mechanism, that's actually a pretty high risk or a red flag for referral. And then for others, wherein they're getting a pretty straightforward injury, say a clavicle injury that should heal in about 6 to 8 weeks, but it's just not healing enough, whether clinically or radiographically, you're just not seeing enough callus. We start to think about, bone health in that setting. And then, as mentioned yesterday by our colleagues in ortho and in rehab, and also this morning by Dr. Davis, patients with immobilization may be at risk for impaired bone health. So think about these things when you're seeing your CP patients or patients with other neuromuscular conditions. And then lastly, other ortho associations have been seen between vitamin D or impaired bone health and some ortho conditions. And so for SCFE or scoliosis, things like that, especially if they're operative, we tend to evaluate their overall bone health just to be sure. So modifiable factors is something that we'll spend a lot of time on because this is something we can do something about, right? This is something we can improve. So we'll start with a diet. I always ask about, special diets, restrictive diets, and you got to ask very specifically, whether it's for social or cultural reasons. So say, they want to be vegan or vegetarian, or, whether it's because it's for a medical reason, they have to avoid dairy or, have gluten-free, or if your, kid is, maybe having a behavioral condition, say they're on the autism spectrum and they're very picky eaters, right? You always want to think about these specific questions that may lead to inadequate nutrition. Studies also show that individuals who have high protein in their diet or high sodium may be associated with reduced calcium retention. And then there's good studies on this and actually published in the AAP showing that kids, especially who consume soda, they're less likely to take milk and calcium in their diet. And then lastly, obesity. So we mentioned earlier that vitamin D is essential for absorbing calcium in the gut, right? And vitamin D is a fat-soluble vitamin, and therefore vitamin D can sometimes be sequestered into the fat cells in obese individuals. So weight management is very important. Thereby, these individuals having low vitamin D levels and impaired bone health. In addition to diet, lifestyle is also an important modifiable risk factor. So as we've heard from lectures yesterday and today, impact helps build strong bones. So those who are sedentary may have impaired bone health. We heard from Dr. Davis's talk this morning. There is a checklist from the ACSM to evaluate, an individual's physical activity. If they're an athlete, it's important to ask what kind of sports do you do? Are you a high impact athlete, runner, jumping athlete, or are you low impact? Are you a cyclist, swimmer, right? It is also important to ask about those who are not necessarily in organized sports. So say, do you have PE, right? Do you have PE? How many minutes in a day? How many times in a week? If you don't have PE, I'm hearing a lot of, especially the older kids don't have PE anymore, right? Do you have recess? Do you have opportunities to run and jump, right? They say really there's none of that. They're very inactive. You ask, do you have opportunities wherein you're like walking home or to school or, taking public transportation or having recreational activities during after hours or on weekends? Really, you want to ask about specific lifestyle factors that you can improve to optimize their bone health. And then next, sleep. Sleep is very important, and I believe sleep is important for a lot of different reasons. At first, when I was reading about sleep and bone health, I was a little bit skeptical. I was like, how does that work? But that article with a photo over there is actually from a study that was out of University of Buffalo. It looked at 11,000 postmenopausal women and who's had DEXA scans in their institution, right? So what they found was women who slept less than 5 hours each night actually had lower BMD compared to those who slept 7 hours each night. And so, the researchers explained that, the body undergoes an array of healthy processes during sleep, including bone remodeling, during which old tissue is removed and new bone is formed. And so what they're suspecting is that if you're sleeping less, then maybe bone remodeling isn't happening properly. It's science. You gotta sleep. All right. And then last but not the least, we can't have a sports talk without discussing athlete-specific factors, right? So the female athlete triad was first described in 1997 by the American College of Sports Medicine. It described this phenomenon wherein female athletes who had eating disorders were losing their periods or having amenorrhea, and also sustaining stress fractures or being considered osteoporotic. So the red triangle on the left hand corner. Over time, they expanded the definition of the female athlete triad, saying it's not just a triangle, it's a continuum or a spectrum, wherein an individual doesn't always have to live in the red triangle. Sometimes they travel back and forth. Sometimes they're optimal energy, optimal periods, and optimal bone health. Sometimes they're in between, sometimes they're in the deep end. Over time, in 2014, the ACSM and the International Olympic Committee came up with a term relative energy deficiency in sport, or RED-S. So what's different? What they realized was, one, the main culprit was low energy availability. So it's not necessarily eating disorder or disordered eating, but individuals who are just not taking in enough nutrients or calories for the amount that they're spending, for example, on exercise, right? So low EA causes not just menstrual dysfunction or stress injuries, that the triad is only one slice, for example, of like this big pie that also implicates other organ systems. More importantly, with RED-S, low EA is not only linked to physiologic complications, it's also associated with performance complications, which now gets the attention of our athletes. And then last but not least, as mentioned in Dr. Watkins' talk this morning, red S is not just limited to women, but also men. So earlier she mentioned, low BMI or thinness in men is associated with increased risk for overuse injuries in male runners. So that's kind of the same concept. So now we move forward to our second objective, which is reviewing strategies to optimize bone health in children and adolescents. So we already talked about this, right? Review their overall general health, which is why, they come to me for a 15-minute, clavicle fracture. We end up talking for 45 minutes, right? We really have to be very thorough about our questioning. Ask very specific questions, dietary practices, avoiding certain food groups, things like that. Do you restrict anything? Are you picky? Is any type of food, bothering your stomach? Ask about physical activities or lifestyle. Again, quantify and ask what type, what quality, and then menstrual dysfunction. In the past, we asked about menarche and, when they've started their periods. There's an age, usually after 15 or 16, that we'll say, oh, you're, running a little too late. You have to, undergo a workup. But I think it goes beyond that. You want to know if they're having regular cycles. And while, our young adolescents may have irregular cycles, I usually ask for a specific number because I've been burned once before wherein someone said, oh, I'm regular. And when you ask how many, they're like 6, which I was like, nope, that's not regular. In the literature, it says that, individuals who are getting less than 9 cycles a year should be considered risk factor for, things like low EA or red S. And then lastly, fracture history. So, it's more than just asking, how many fractures have you had in your lifetime? What kind of fractures did you get? What kind of mechanism was it from? Was it high velocity, such as trampolines or, monkey bars, which, are reasonable ways to get bone injuries or, does make sense for a lot of kids. And ask, what kind of treatment did you need? Was this something that healed in about 6 weeks? Was this something that needed that took longer than expected to recover? I think those are, very essential data points. Look at their family health. Again, from Dr. Lawson's talk yesterday, she mentioned that, a lot of the chronic medical conditions, would be higher suspected in individuals who have positive family history. And then lastly, especially for those who see patients in primary care, looking at their measurements or their growth chart, you might get, little clues about their overall state of health. So the American Academy of Pediatrics does not recommend routinely requesting labs for everyone. However, if they have a few of those risk factors I mentioned earlier, they advocate for everyone to be proactive about this. A good place to start is vitamin D levels. And the type of vitamin D to check is the 25-hydroxy vitamin D because it adequately reflects the storage amount of vitamin D. And although the definition for deficiency is less than 20, we want it to be over 30 for children and adolescents. And the reason is because 30 and above seems to be the number that's preventative of fractures. So it's not enough that they're not deficient, but we want them over 30. If you, get a vitamin D level and it says, less than 20, they're considered deficient. There's a few different ways to treat it. This table should be in your syllabus. There's daily dosing and then there's weekly, once a week bolus dosing. We usually give that bolus dosing for about 6 to 8 weeks. We encourage rechecking those levels after 6 to 8 weeks to see where they're at. If they're still low, then, treat them for another round, or if they've bumped up a little bit, then adjust your dosing accordingly. 20 to 29 is considered insufficient, and so the AAP and the Endocrine Society all recommend supplementing these kids with vitamin D. And then 30 to 50 is considered sufficient or optimal, and for these individuals, there's no need to give them additional supplementation. Whatever they're getting from the diet or for other sources like sunlight should be enough. Similar to, our rheumatologic talk yesterday, you can get other labs depending on the clinical picture. So a CBC, can give you an overall state of health, show if there's anemia, chronic disease, look for any pancytopenias that may be hiding. Electrolytes is an easy way to kind of look at their liver, GI, and kidney function. If you're thinking this is, more of an inflammatory condition, Dr. Lawson encouraged ESR and CRP as a good baseline. And then if you're thinking of endocrine, you can consider hormones like PTH. DEXA scan is an imaging modality that measures bone density. And DEXA scan should only be ordered in patients with primary bone disease or at risk of secondary bone disease when patient may benefit from interventions that decrease, their risk for clinically significant fractures. It is usually okay to just defer to a specialist to do this. I myself, reach out to our endocrine specialist to make sure I'm, getting the DEXA scan appropriately. But I just wanted to mention a few different details about pediatric DEXA scan that make it unique compared to our adult protocols. So the pediatric protocol looks at the PA view of the spine and the total body less head. In a pediatric DEXA scan report, we use Z-scores, so you shouldn't be seeing T-scores in there. T-scores are used in adults. Z-scores are standard deviations from sex, age, and race and ethnicity matched reference ranges. Anything that's above -2 should be okay in children. A Z-score that's at -2 or less is considered low bone density. And according to the guidelines, the word osteoporosis should not be used in a DEXA scan for children, but it's more of a clinical diagnosis. So if you have low BMD and you have a clinically significant fracture history. So these include vertebral compression fracture from low energy trauma, or 2 or more long bone by 10, or 3 or more long bone fractures by 19. And that's something that our endocrine specialists have shared with us. Next, diet and weight management are essential in optimizing bone health. As we learned this morning, too low BMI risk factor, too high BMI is a risk factor. We said earlier, individuals who have high fat or high sugar in their content in their diet, it may impair their calcium intake. High protein or high sodium may be associated with calcium loss in the urine, and then obesity, right, sequesters vitamin D into fat cells. The photo on the right side is the athlete's plate. This is something that I've learned from our nutrition specialists that they recommend to athletes for different phases of training. There's the different compartments, but the bottom line is that all macronutrients are essential. So there's carbs, there's protein and fat, and that higher intensity training requires more energy to fuel the athletes to avoid red S. So the bottom photo over there is for hard training. As you can see, like 50% of the plate is for carbs. Next, calcium and vitamin D. According to the AAP, most kids do not need supplementation for any vitamin, really, but if they were to need it, it's usually calcium, D, or iron. So this table is the RDA, or recommended dietary allowance, for calcium and D. For calcium, as you can see, as a kid gets older, the number gets bigger. Makes sense. What I wanted to highlight in this slide was that 9 to 18-year-olds need 1,300 milligrams a day. Do you guys know how much milk that is? Right. So this is the table that shows us, dietary sources of calcium. As you can see, one serving of milk is less than 300 milligrams, right? So a teenager needs about 4 glasses of milk just to get their RDA for calcium. Obviously, there's non-dairy sources. And so, I show this table to families, and I'm like, well, if it's just not meeting your RDA, then, feel free to supplement as needed. Similar story goes with vitamin D. So our RDA for vitamin D really is not that high. It's like 400 or 600 IUs. However, if you look at the natural sources, they're salmon, sardines, mackerel, tuna, shiitake mushrooms. Like, whose lunch whose kid has that in their lunch, right? And so, I always push for, dietary sources. That's always encouraged. I always point out non-dairy sources. I always point out, fortified, sources for these calcium and vitamin D. However, if you feel like, they're very picky or there's any issues with obtaining these naturally in their diet, then, supplementing with vitamin D would be recommended. And then last but not the least, exercise. I was just reading an article this morning from BJSM, and this is like very similar studies that they've done in a lot of different, conditions. Exercise versus X medication. Exercise always wins, and improving, symptoms, improving outcomes. And so, like I mentioned earlier, impact helps build strong bones. And so physical activity is part of our strategy to optimize bone health in children and adolescents. The AAP recommends 60 minutes of moderate to vigorous exercise each day. But when we're trying to look for low-hanging fruit, studies show that 20 minutes 3 times a week has shown significant bone growth. So if they're at least getting that, then let's encourage that method. And then again, the type of exercise matters. High impact is how we have stronger bones, better BMD. And so if you're dealing with swimmers, especially who hate their dry land exercises, make sure they have some form of impact or include plyometrics or resistance training into their routine. And then for those who are high impact athletes, as we heard in the lower extremity ovaries injuries earlier, making sure they're gradually increasing their load, they're managing their load, they're having adequate rest, make sure that they're practicing all those things to make sure we're avoiding stress injuries. And so with that, I end my talk with 2 minutes to spare for question and answers. Thank you.